Hello everyone. Let us discuss today a very interesting case. I have already written the relevant clinical feature, examination finding, focus history, imaging lab values. So let us discuss what is the problem here, right? From the history and examination, patient is a 70-year-old male, old age. Secondly, he is a smoker and subsequently has developed COPD on inhaler at home. He presented with fever and chills with cough. So here the infection is being localized to the lungs. Or patient is having a systemic infection where lung is also involved as a part of systemic inflammatory response. But prima facie, lungs is the source of fever, and from today morning, patient has developed shortness of breath. So this again signifies that lung is the source of infection here. But the important thing here is that although we can pinpoint our infection to lungs, patient also had confusion and diarrhea, which is unlikely of a patient who is having lung infection. So these are unlikely for a lung infection. Now coming to the examination, patient is having high grade fever, but you can see the heart rate here, it is 70 per minute. So for a temperature of 101 degree Fahrenheit, this heart rate is very atypical, isn't it? And patient is not on any beta blocker. Blood pressure is okay, respiratory little bit tachypnic, patient is requiring supplemental oxygen via nasal cannula. On examination, on auscultation, here you can see there is bilateral crepes up to mid zone. This is significant. Usually, when we have a pneumonia, there is a consolidation in the lung, so you can hear a bronchial breath sound in the lungs. But here, bilaterally, there are crepes, and also patient is confused. So there is altered mental status. In the imaging, we see WBC count is high, suggestive of infection or inflammation, because here we have already localized the disease to lungs, so it is most probably infection. Hemoglobin is okay, platelet is okay. Sodium is 125. Patient is not on diuretics, but still there is hyponatremia. Why this patient has a hyponatremia? There is no history of vomiting, nothing. And potassium is okay, urea is a little bit higher side, maybe secondary to dehydration, creatinine is okay, bilirubin is 0.4, and X-ray is again bilateral GGO up to mid zone. This is again unlikely of a consolidation. So now based on these things, let us discuss the case. So fever plus cough, this is called upper respiratory tract infection. Fever plus cough plus a patch or consolidation in the lung is called pneumonia or lower respiratory tract infection. But in this particular case, what has happened is there is no consolidation in the lung. However, as you can see here, that is bilateral GGO up to mid zone. So here the X-ray is right. So this is something not usual. In this case, we have done one ECG, that is okay. Echo, that is okay. NT-proBNP, a marker of heart failure, that is also okay. So there is no heart failure. This is something that is atypical of a typical pneumonia, right? Also in this case, we have some other very atypical things. Starting from the beginning, patient had CNS feature, confusion, patient has GI symptoms, diarrhea, patient has decreased sodium, that is hyponatremia. The heart rate is low, which is unexplained. With a fever of 102, heart rate is 70, that is very low. That is without any beta blocker in the past. So this you can call relative bradycardia. And also we've seen chest X-ray, the presentation is not typical of a pneumonia. So this is a pattern, and this pattern is specifically found in the disease is called atypical pneumonia. Especially in this specific case, the organism involved is Legionella pneumophila. especially the serotype 1 that is responsible for 80% of disease. So now let us discuss the spectrum of disease. This Legionella pneumophila, serotype 1, which is responsible for 80% of the disease, it can manifest in two ways. So number one is Pontiac fever. This usually happens in young patients, immunocompetent patients, right? And it is self-limiting. But the second one is this is called Legionnaires disease. This specifically happens to who? Those who are old, immunocompromised, especially in patients who are having COPD, smoker. They develop the life-threatening part of the disease, which is called Legionnaires disease, right? So it can present as a community-acquired pneumonia or hospital-acquired pneumonia. Now, how to diagnose it? So number one is any kind of pneumonia, the diagnostic process is a sputum culture. But in this particular case, for this particular organism, we would have very specific culture media that is called buffered charcoal yeast extract. It's a difficult culture media and the growth is very slow. So sputum culture takes a very long time, growth is slow and yield is low. Second is we do a blood culture. Blood culture is not recommended in community-acquired pneumonia because the yield is low. Especially in this case, this organism is very difficult to isolate from the blood. So what to do here? Urinary Legionella antigen testing. And it can diagnose with certainty the Legionella pneumophila serotype 1, which is responsible for 80% of the disease. So this is again very, very atypical because in pneumonia, usually we check for sputum, if not sputum for blood culture, but never urinary. But in this case, we check for urinary regional antigen. Now one may ask, what about the other 20%? If your clinical suspicion is high, urinary antigen test negative. Here what we can do is, we should check for the PCR in a respiratory specimen. This can be sputum or bowel fluid. This is for the other 20%. So now once you've diagnosed it, what is the treatment? The drug of choice remain respiratory fluoroquinolones. What are the respiratory fluoroquinolones? It starts from levofloxacin, moxifloxacin, not ciprofloxacin. Ciprofloxacin is a urinary fluoroquinolone. So this is the first line. Second line is macrolides. Among macrolides, we can give azithromycin. The drug of choice remain respiratory fluoroquinolones. What about combined therapy? The studies has been done. It is not superior to single agent. However, in specific situation like Legionella endocarditis, in those situations, combination therapy may be helpful, not indicated, not recommended. So you can give levofloxacin plus azithromycin, right? The duration, of course, the patient when sick, you start with the IV formulation, then gradually change to PO when the patient can take diet. Usually the duration is 7 to 14 days. So there are a few questions need to be answered. Do we need a CT scan? HRCT chest? Answer is no. Usually HRCT chest is not required in community-acquired pneumonia because chest X-ray and antibiotics are enough to treat the patient. Only if after giving more than 48 hours of appropriate antibiotic, patient still remains symptomatic, then you do a HRCT chest to rule out other mimics or other diseases, right? Number two, blood culture. Blood culture is not indicated in community-acquired pneumonia because yield is low. It is especially recommended in hospital-acquired pneumonia or healthcare-associated pneumonia. So in this case, blood culture yield is low. We do not do it. Sputum culture usually done in community-acquired pneumonia in some cases, but here also it requires a specific culture media and the yield is very low. We do not use it. As you can see, unlike for a typical pneumonia, there is no consolidation specified to a specific lobe of the lungs. The both bilateral lungs are involved, and typically it is a groundless opacity, not a consolidation. This is typical of atypical pneumonia like Legionnaires disease. Also, patients present with atypical signs and symptoms like confusion, GI symptoms like diarrhea. This hyponatremia is actually SIADH, and the heart rate is low, that is unexplained. It's called relative bradycardia. So many atypical things are there. Another atypical thing is sputum is not diagnostic, unlike typical pneumonia. Here we have to check for the urinary antigen testing. Only if it is negative, then for the rest 20% of the disease which is caused by other serotypes, we do a PCR in the respiratory specimen. So this is the reason why this is called atypical pneumonia, because everything is different from a typical pneumonia. Thank you very much.